Hello, everyone. Welcome back from lunch. We're going to give folks a few seconds to get out of the waiting room and into the main session here, and then we will get started. All right, I'm seeing a solid number of people, so I'm going to go ahead and get going. This is being recorded, so you can always come back and listen to my housekeeping remarks if you need to. Welcome to our after lunch session. Today we are going to be talking about fentanyl exposures in young children, and we have a fantastic panel lined up for you. We have Dr. Temple and Dr. Hendrickson, both from the Oregon Poison Center, and Dr. Phillips from here at the Washington Poison Center. Before we get started with them, just a couple items to go through. I'll have Alex or Justin pop into the chat box the survey link. You've seen it in every session, folks. Just a reminder to wait until the end of the sessions that you're watching today to fill it out. You don't need to fill it out after every session. Please do that if you need a certificate of attendance or if you just want to provide us with some feedback. We always love reading your comments and tailoring the series every year to what you all are wanting and needing. Please put all of your questions in the Q&A box today and ask lots. We're going to have just like a small amount of presentation at the beginning of this session, and then we're going to dive right into questions from you. We have some that are pre-built here, but we really want to make sure that this session is meeting what your educational needs are. Please put any other comments or discussion points in the chat box or introduce yourselves. We'd love to see who all is attending here today. Alrighty, I am going to first have our panelists introduce themselves before we dive into presentations. So, Dr. Hendrickson, I see you're unmuted. Go for it.
Yeah, hi everyone. My name is Rob Hendrickson. I'm a professor of emergency medicine and section chief of medical toxicology at Oregon Health and Science University in Portland, Oregon, and I'm the medical director for the Oregon Poison Center.
So much. Dr. Temple, go ahead.
Hi, everyone. I'm Courtney Temple. I am one of the faculty also at Oregon Health and Science University, as well as the Oregon Poison Center, a former fellow of Dr. Hendrickson. I have been increasingly becoming more interested in pediatric illicit fentanyl exposure. So this panel will be a perfect discussion today.
Wonderful. Dr. Phillips.
Well, thank you and welcome, everyone. It's great to be here. I'm Dr. Scott Phillips. I'm the executive and the medical director of the Washington Poison Center, and privilege of working with Megan and Alex and Justin on this great program. So welcome, everyone.
Thank you all so much. And I just want to note one last thing before I turn it over to Dr. Temple. Actually, go ahead and get your slides pulled up while I say this. Today is National Fentanyl Prevention and Awareness Day, which is when we come together to remember loved ones that we've lost, acknowledge the devastation that fentanyl has had on our communities, and educate and raise awareness of how we can prevent and reduce harm from fentanyl. So this session today is very perfectly placed. All right, I will turn it over to you, Dr. Temple, to get us going. Thank you.
Great, thank you. So again, thank you everyone for being here. I just want to take a couple of minutes to introduce our Poison Center in Oregon and some of the statewide trends that we've been monitoring, as well as some of the specific data we've been able to identify related to pediatric illicit fentanyl exposures. And then I will turn it over to Dr. Phillips for the Washington rundown before we open up the panel to discussion. So I have no disclosures today. And just to begin, for any of you that are unfamiliar with the Poison Center model, our Poison Center in Oregon fields about 50,000 cases per year, both from healthcare facilities and homes. And this might mean that we have parents calling for advice on exposures that are ultimately benign, working with families for home monitoring of more significant ingestions to safely avoid unnecessary hospital or healthcare visits. And conversely, this also means we work with families to provide rapid real-time advice along with our specialists in poison information, who are our amazing nurses and pharmacists. And that might be for dangerous or life-threatening exposure. So we continue to work with the inpatient teams for management through the ER, the intensive care unit, and with all of the specialists that are involved throughout the patient's care. And we might interact with field agents like EMS, hazmat, emergency response teams for other exposure concerns. But the poison call center system and the toxicology specific national database that we use, we're able to look for signals and patterns of concerning incidents. So today we're going to talk about specifically the uptick that we've been monitoring in the pediatric fentanyl exposure concerns. So the fentanyl epidemic has become, rightfully so, a hot topic over the past couple of years, but it really didn't make its way into our region until about 2019. So this is a recent publication out of the OPC, and we previously had no signal of illicit fentanyl exposures in children under 6. And we looked at that category specifically to capture children who are more likely to engage in exploratory ingestions because, of course, those tend to be the ages where they put everything in their mouths. And then right around 2021 is when we all of a sudden see this spike in calls, and it mimics very closely the national spike as well. And we think that little delay between 2017 and 2018 to 2021, when we started to have cases, is probably the delay in community availability as it was coming across the country. So we went from having no cases to 2 in 2021, 9 in 2022, and 16 in 2023, which fits really well with this national curve that's also gone up by about 700%. Then we took a step back and we took a closer look at some of the cases that we could review in terms of the more granular clinical course data. And this is a table of 5 children who were admitted to a single PICU. And all of these children were admitted for opioid toxicity, which was confirmed via urine or expanded testing for fentanyl. And again, all of these kids are less than 6 years old, and every exposure occurred in the home. So this wasn't an exposure out in the community. It was in their home environment. 2 children ingested a powdered product, 2 ingest a pressed tablet, which I'll talk about on the next slide, and 1 was an unknown formulation. But all of these children had such significant mental status changes, central nervous system depression, and respiratory depression, to the degree that 3 of them required intubation to support their respiratory status, and 2 of them required CPR, and one of the cases of CPR was actually started by a parent in the home. In most of the cases, naloxone was given, although that lone case at the bottom, no naloxone was given, but the child was intubated for nearly a day in the ICU for supportive symptoms. There are 4 others that received bolus dosing of naloxone in the field, and that was sufficient enough for 1 child. A drip was planned but never initiated. That's patient 3 there. But all the other patients required drips ranging from 8 to 36 hours in duration to control symptoms. And again, all 5 of the children tested positive for fentanyl. And we had essentially ruled out any pharmaceutical fentanyl exposure. And upon further questioning, parents and family members had admitted to use of illicit fentanyl in the home. So one of the considerations for all of this data is that we tend to think of fentanyl as a pretty short-acting medication when used in a clinical setting and when it's dosed appropriately. But now that we're seeing the advent of these pressed tablets, sometimes called blues or M30s, data from the DEA surveillance programs are reporting instances of up to 4 milligrams of fentanyl present in each tablet. And actually, this tablet specimen is from Washington, but we have very similar findings in Oregon. This is just one of the more profound doses of fentanyl. And for reference, we dose fentanyl in micrograms, not milligrams, because of its potency. So many adults will smoke this, as you can see in the photo on the right. And that sort of means that they have the opportunity to self-titrate, meaning they have some control over the dose of the exposure dose. But for a toddler to ingest a full tablet like the one shown here, they could be getting as much as 40 times the safe dose of fentanyl for a child. So we think, along with smaller size, lower body weight, relatively naive to opioids, that's generally the finding in children. Children usually don't have prior exposure to opioids. And this overall massive dosing is what is contributing to the severe and persistent toxicity we're seeing. And just a final slide here. This is a graphic that Dr. Hendrickson actually made of the DEA seizures of fentanyl in Oregon compared to the number of pediatric exposures starting in 2019 when it came out to our area. So there's a very clear correlation here between this data, and it implies that the more fentanyl that's available in the community for the DEA to seize makes it more likely that children will be exposed for a multitude of reasons. So unfortunately, we expect these numbers to continue on this trajectory. So continuing to collect and analyze data and talk openly about this issue is going to be critical for public awareness and mitigating strategies. So with that, I will hand it over to Dr. Phillips to talk about some of the Washington data.
Okay, great. Well, let me pull this up here and we'll get started. Thank you again, everyone, for attending. I'm going to mirror some of the data that our colleagues in Oregon presented because it's important to compare both things. I also have no conflicts to disclose on this. I think it's important also to understand, contrast and compare the two states. We're quite similar. We get slightly more phone calls than Oregon. We get about 62 to 63,000 a year. And part of that is because of our population being greater and our population density being significantly higher, and Oregon having a larger area for their state. So we're fairly comparable, except Washington has more bodies within the area. This is really the meat of the matter, and I put this together to kind of compare it with Oregon data and national data. And you can see here the blue is national data, red is Washington data, and the purple is Oregon data from their slide. And you can see we had a very similar process. We might have had a little bump earlier than Oregon, but essentially we had the same thing with greater cases, and particularly in 22 and 23. And I didn't put in the 24 data. I thought it was important to keep comparing apples to apples. Also, if you look at US population, Washington population, Oregon population, and then combined Pacific Northwest, you can see the total number of percent of cases. And what you can see is that Washington and Oregon are overrepresented comparing to the rest of the United States in the number of these cases that are appearing. I'm not exactly sure why that is, and I'm hoping Dr. Hendrickson and Dr. Temple can answer that for me, but we are seeing this increase more so than the national trend, and I think that's an interesting finding that we have. Within our data, our mean age for kiddos under 5 years is 1.7 years. In all years looked at from 19 to 23, and just 23 essentially the same type of ages we're seeing. If we look at adolescents, I threw this in just for comparison. They're obviously a little bit older. They're in the 14 to 15 age group category. So if we look at the sites of exposure, I think this is an extremely important thing to consider here. Both Oregon and Washington, most of these exposures are occurring in residences. So we have young children less than 5, most closer under 2 years of age, and essentially occurring in home, indicating that there's availability and that the children have somehow able to have access to it. Very rarely are there other sources unknown or other residents, one from a restaurant. But if we just look at 23, we see that the vast majority include their own residence or a public area. Public areas can be daycare, schools, other areas like that. So that's kind of interesting. If we look at the 16 to 18-year-old, again, we see a lot of this occurring in their own residence, and that's increased with age, as well as a little bit more in public areas. So, and this trend has been increasing. So more and more of these are occurring in homes. So I think that's important that we're seeing a significant rise in both states, that they're mostly occurring in homes. And the other point I'd like to make is that most pediatric arrests that occur typically start with a respiratory arrest. And so I really want to advocate for naloxone in the homes of all these places, because any pediatric arrest needs naloxone as part of that protocol as well. So with that, I'm going to stop sharing and turn it back over to Megan for our Q&A session.
All right. Thank you, Dr. Phillips and Dr. Temple. So folks, please start typing out your questions in that Q&A box. I'll get started on some of our questions that we've put together already, and then we'll start asking yours as they come in. Well, first, I think just to follow up on one of the points that Dr. Phillips made, Dr. Temple and Dr. Hendrickson, any theories as to why Washington and Oregon are overrepresented in this data?
This is Rob Hendrickson. Yeah, I mean, we don't know. I think that's important to state right up front. But I do have some theories, and I think that the tablets, the pressed tablets that Dr. Temple was referring to, may have some factor. You know, regionally, we have different drug supplies and sources, and tablets were very common here and continue to be very common, although there's some increasing amount of powder fentanyl now. I think it is much easier for a child to find a tablet and to put it in their mouth than it is to find a pile of powder or a baggie of powder and to kind of put that in their mouth. They certainly do it. We certainly see lots of children get into methamphetamine and things like that. But I do think that those pressed tablets may have some factor. But, you know, I'm sure there's many other factors as well.
I don't know that I have anything to add to that. I would say the same thing. We don't really know, but again, tablets are easier to ingest, especially with children, right? So if we're comparing ourselves to other regions in the country that don't have as many of those tablets, it's possible that accounts for some of our overrepresentation. But again, I think Dr. Hendrickson's right. This is probably multifactorial, and you know, as we continue to analyze the data, maybe some signals will come out of that.
Perfect. Thank you both so much. All right, questions are starting to come in now. So we'll start with this one from April. Community members often express concerns about the increasing amounts of used needles left in public parks and other public spaces frequented by children. Have you had any cases of fentanyl exposures from situations like this? Dr. Phillips, do you want to start us off on this? Oh, you're muted.
Yeah, we've had cases that have been called into us about concern in public spaces like parks with needle exposure. It's unusual typically these days for people to use fentanyl with needles. It is still done, but it's not that common. Where we think about other drugs that are more commonly used intravenously. And so while we have it, it's difficult to prove. The cases that I've dealt with from parks specifically, where needles were around, the child didn't have what we would call the clinical syndrome that would look like an opioid or a fentanyl case. So it's always good to be aware of your surroundings and what's in your surrounding and what your kiddos are having access to and putting in their mouth. But we just haven't seen it in association with needles yet.
Anything to add, Dr. Temple or Dr. Hendrickson?
No, I would just say we are seeing the same thing. Almost all of the fentanyl use in our area is smoking. But there certainly are some people who are using needles, but it seems to be a pretty small population. So no, we have not had many cases where certainly we weren't concerned about the exposure to fentanyl, but we haven't had many needle sticks or things like that in children.
I think that the first part of that question is really interesting too, about community members expressing concerns about these public spaces. And I think we hear that narrative a lot of kids getting into things in public spaces, but the reality of what we're seeing is not that. Do you three have any thoughts behind, what is driving that narrative of the public space?
Well, I
Well,
think part might be that there's a bit of a lack of knowledge about this. And if you looked at our data and data from Oregon, most of these exposures are happening in homes. They're not happening in public places. We're seeing pretty uncommon from the cases. Now, they're both small numbers of patients, but it's still not a commonplace. Of course, it's still important to be aware of your surroundings and what your kids have access to.
I would also add, I think that the cases that are happening out in the community are the ones that make the mainstream news. So I think that that is what most of us are hearing about on a more regular basis. And it's being shown to us on TV or in newsprint. And we're not hearing about the ones in the home so much. It may be discussed in the user community, but certainly not in the broad, public health sort of discussion. So I think that is some of where this message is coming from.
And I would just add that the exposure, I know there's a lot of media about exposures in parks and things like that, and those types of public spaces. The ones that when we went through our data, those types of exposures were almost exclusively someone who smelled fentanyl smoke in a park, as opposed to, ingested a tablet, had severe toxicity, was hospitalized. Those were sort of very different events. So when I think to underline some of the facts that we've stated already, if I remember correctly in our study, 92% of those cases happened in the home. So these were families, someone in the family or in the home either was using fentanyl or brought fentanyl into the home, and the child was exposed there. So the percentage of people who are exposed in their home is much, much, much higher than anything that we're seeing out in the community.
And I think that also begs the question a little bit about safe storage. And that's, I know, something that our educators talk a lot about, is even people that might be using fentanyl, there's still a role for safe storage in these environments where kids are present.
Yes, thank you for underlining that message, Dr. Phillips. Going back to Dr. Hendrickson, what you were saying about getting calls from people who may have been at a park and they inhaled secondhand smoke. We do have a question here from Alicia asking, what can you tell us about fentanyl exposure to secondhand smoke?
Yeah, what I would say is that first of all, fentanyl has a pretty unique and not very palatable smell to it. So most people who are exposed to it, they know that they've smelled it, because it's I wouldn't say noxious, but it's not a pleasant smell. So people tend to know. And also when people are exposed to smoke, anything, anytime you're burning something or heating something, there's going to be a bunch of particulate matter and a bunch of chemicals in the air, and a lot of those are irritants. And so what we have seen has been certainly people can get symptoms based on those types of exposures, things like irritated eyes, a headache, feel nauseated. But those types of secondhand smoke exposures are not going to expose you to enough fentanyl to develop fentanyl related symptoms. So you're not going to get sleepy and stop breathing.
Can I ask, we have a question from one of my Poison Center colleagues. You're right that fentanyl smoke does have a very distinctive smell. Do you know if that is from the fentanyl itself or from what it is mixed with, the cut?
I wish I knew the answer to my question. I don't know. I know that when we handle fentanyl in the hospital, it doesn't smell, but we're also not heating it. So I don't know. What I can say is that the tablets, what we have seen, at least in Oregon, is that the tablets, the bulking agent in the tablets is mostly acetaminophen. And in the powder, most of it has been mannitol. neither of which give that really, sort of potent smell that some people refer to as like burnt popcorn. It's a very unique smell. So no, I don't know what it is. If anyone else knows, please. I'm eager to learn.
Apologies for throwing the niche poison center questions at you. All right, let's move on to this next question here from JW. In your studies, what are the percentages of racial, ethnic, and economic demographics of the pediatric exposures? I recognize that's going to be hard to answer with poison center data, but any thoughts?
Courtney, if you know more, then please pipe in. But so we don't collect. It was poison center based data, so we didn't collect race or ethnicity. So we don't know. I will say that they were the cases were concentrated in urban areas, which is not very surprising. I think that's where most of the fentanyl is being used. But we did not have. We have a very small number of cases, but we didn't have. They were all in urban, sort of tightly grouped in urban areas, and that we didn't have much in the way of rural. But besides that, I can't really say.
Yeah, I was pausing to let one of you maybe answer if you had any firm data, but I don't know. We like Rob said, we haven't collected that data, but it might be something to look at for the future.
And I'm just
likewise in Washington, we don't collect that data either.
Yeah, and I just want to explain a little bit more about why poison centers don't collect race and ethnicity information. We want to make sure that we are a trusted resource in communities, that we aren't presenting barriers to people calling us. So we don't ask questions that aren't relevant to the medical treatment of our patients. So that's why we're not going to ask about economic status, race, ethnicity, etc. Can be a certain limitation in our data, but it ensures that we are able to treat all the people that need our help. All right, next question here. Are the nasal naloxone applicators safe to use with children of all ages? Repeated doses as needed? Any special instructions for use with children?
So my messaging would be to use adult naloxone dosing on any child. Don't hesitate to. I would rather people use an adult naloxone dose on a child than hesitates to give naloxone to a child. And for most of them, it's not really possible to give to figure out what kind of dose you could give that would be reduced. So I would say whatever naloxone you have, they're all designed for adults. And I would just use it, and I would use it in the dose that is, described for adults.
Yeah, so this is a message that I have given talks to EMS on, because we've fielded a lot of questions for them about what to do in the field. And really the answer is, if you have a child that you suspect has a significant opioid, poisoning or intoxication, the answer is to just give them the naloxone. Like, it is a safe drug. It works the same way in kids that it does in adults. That should be the first step to starting their resuscitation process. So give the full adult dose at any time, whenever that's in question.
I think the other sort of basic thing to think about here is that we dose the naloxone to the opioid. We don't dose it to the size of the person, gender, or anything else. So we're targeting the opioid. So it's really the same dose that we're giving an adult or a child. We're targeting that pill or powder, and that's what we're trying to reverse. So there's no need to worry about adult size, child size, teen. Just give. The wrong thing is to not give it.
Yeah, and I'll piggyback on something that Scott said before, which is, one of the interventions, because I think that, making naloxone available to anyone who's using an opioid, whether that's a prescription pharmaceutical opioid or illicit fentanyl or another opioid, just recognizing that, we give naloxone to people so that it's there they may treat their friend, they may treat, it may be used to treat themselves, but also family members that get into their fentanyl, they may be able to use it on them as well. So it's just one more reason to have anyone who's using anyone who's using opioids to have naloxone available in the house or on their person.
I think I will just jump on the back of that about the repeated dosing and what a protocol should be. And I think that's a little bit more of a tricky question. So from one of my slides with the table, you can see that some of the kids got 7 bolus doses before they were initiated on a drip. And usually we will start a drip at a third of the dose that has reversed the symptoms in the patient. So none of these kids fit a single protocol here. And oftentimes I think no one is really following a particular protocol for redosing, and it's more so watching for the improvement of mental status, improvement of respiratory status, and things like that, and then deciding how to move forward. But repeated dosing certainly was needed in many of our cases of severe CNS and respiratory depression. But they all did show some sort of effect after the first dose that prompted people to continue redosing.
And can you clarify, Dr. Temple, for the non-clinicians in this session, what a bolus dose would be?
We have bolus doses available at multiple different doses. And it depends on what the patient looks like. If this is an adult, you may choose to give them a smaller bolus dose to reverse the symptoms enough that they're breathing on their own and their mental status has improved a little bit, but not so much as to put them into acute withdrawal. That's something that we think about in the adult population that has chronic exposure. For kids, though, we recommend giving, a full, 10 milligram dose, which is hopefully what someone has on hand through EMS or the naloxone intranasal spray that we often give out to families. So again, the bolus dosing, there are a couple of different doses, but usually we might choose to use smaller ones in adults, and for kids, we would use a more robust dosing strategy.
Great, thank you for that clarification. Okay, this next question is going to be about dermal exposures. So how easy is it for young infants to be exposed? CPS said it could be on clothes of a parent. Adults really don't absorb through the skin. Is it different for children?
Well, I don't think we have great dermal absorption data on kids. We have to, I think abstract that from adults. And we do know that it doesn't get absorbed through the skin very well. Could it be on clothing? Sure. Powder could be everywhere. And we really are concerned about pills and powder, and it all comes down to the dose of that. So how much could be on the clothing? If it's a trace amount, it probably means nothing and likely will not change things. But for it to get from the clothing to cause a clinical effect, the child would have to either lick it off the clothing, get it enough powder from their clothing onto their fingers and lick their fingers. But it's not just a trivial kind of event. It would have to get from the clothing into their mouth.
Anything to add to that, Dr. Temple or Dr. Hendrickson? Nope. Okay. Next question. Have you seen any calls for fentanyl mixed into cannabis vapes or other products?
Yeah, I know that there's been a lot of attention to this. I have not seen a definitive case where fentanyl has been added to another drug. We're doing a study at the OHSU emergency department where we do a questionnaire on people with opioid overdoses, and the questionnaire is pretty lengthy, 20-30 minutes, and then we measure their blood to find out what drug they took. And we've had several cases where people said that they took meth and got fentanyl effect, something like that. But then when you really drilled down to it, one, they had almost no meth in their system, in their blood at all. And then almost actually every single case has been When you ask them where they got the drug, it's not their normal source. It was a guy or a friend or so what seems like was happening in those cases is they thought it was meth or thought it was cocaine, and it was fentanyl, just pure fentanyl, rather than fentanyl mixed in methamphetamine. There's certainly been reports of fentanyl mixed with other drugs across the country. I just have not seen a real case here that I would say was definitive. It seems like most of these are sort of mistaken identity. Someone thinks it's cocaine and they use it and they have an opioid overdose because they snorted fentanyl instead of cocaine. I don't know if you've had any other cases, Scott.
No, I've heard the same thing, that it's come up. We know that there has been people that have vaped based on refillable vapes. But I think that's really an atypical type of use from our experience. Could be done, but not common.
I'm muted, sorry. The kids that you followed, specifically Oregon, since I know you took a deeper dive into your cases than we did in Washington, were they all fentanyl only, or were there other substances that were also involved in those exposures? And how does that change things when you're treating that patient?
So for the couple of kids that I had listed in our table, 4 of them were fentanyl and norfentanyl metabolite. And one of them also had methamphetamine. That was at a much lower concentration than the fentanyl, though. So I don't think it changed management at all. And it suggests that what we're finding from these kids' ingestions is really that it's pure fentanyl. It's really nothing else. And the acetaminophen concentration of these pills really has come under the toxic dose. So that hasn't been a consideration either. And then there are some other byproducts that are found in the pills that really are of little concern. So again, 4 of the 5 kids were only fentanyl and metabolites, and one of them had a minor concentration of methamphetamine.
And I can add from that study that I was talking about, I have blood results on 37 opioid overdoses so far, with more coming soon. 100% of them were fentanyl, 0 fentanyl analogs, 0 heroin, 0 oxycodone or other pharmaceuticals. That we're just seeing fentanyl. That said, very interestingly, all 37 had these are all adults, had at least trace amounts of methamphetamine. So we should add that from the user perspective, it is extremely common, if not universal, to be using both fentanyl and methamphetamine, but we haven't seen them mixed together. They're using them as individual products for a variety of reasons.
Excellent, thank you. All right, we have a scenario question here. What if a young child is sitting on a parent's lap while they are smoking fentanyl? Any info about the risk of fentanyl toxicity to the child from this type of exposure?
Well, that's a hard one to answer because you don't know all of the circumstances. Our goal is to separate the child from the fentanyl and the adult from the fentanyl. So is this fentanyl powder? Is this just smoking a tablet from foil? There's a lot of variables there, but ideally children shouldn't be around fentanyl because it doesn't take much for someone to be using fentanyl and pass out from the effects, and then have the child have the opportunity to ingest the tablets or play with the powder. So it's never a good idea. It doesn't necessarily mean that the child is going to get an opioid overdose from inhaling secondhand smoke or side stream smoke from the parent, but I would say that's a rather dangerous scenario to have a child sitting on your lap while you're smoking, just for all of the potential possibilities that we can't plan for.
You, Dr. Phillips. Okay, next question. What is known about long-term developmental and health effects of young children who have experienced opioid overdose or low-level longer-term exposure, like through human milk?
I would say that there's almost nothing known about that. Obviously, well, I was going to say we hope to have, I hope to have some, information eventually, but I hope we don't ever have that information because I don't want children to be exposed to fentanyl. But I don't think, there's certainly no long-term studies on exposure to illicit fentanyl or smoked fentanyl, the other products that are created when you heat fentanyl, breakdown pyrolysis products, things like that. Yeah, we just don't know. As far as the breastfeeding goes, I don't know. I'm wondering, Scott, if you've heard, or Courtney, if you've heard of any actually well-documented cases. I don't know of any well-documented cases where the child got opioid toxicity from, breast milk, but for certainly fentanyl is in breast milk in very, very small quantities. So, and I don't know, and I don't think anyone knows what the long-term ramifications of being exposed to very, very small amounts of fentanyl through your first couple of years of development is.
I have a follow-up question to that, which totally fine if I know none of you are experts in this area, but what about like buprenorphine being passed through breast milk? Are there any studies on medications for opioid use disorder in pregnant people and infants, I guess?
Yeah, I would say that there's very limited data on breast milk, period. The contents of breast milk in breastfeeding women who are using opioids. That said, there are many, many cases where, opioids we expect to appear in the breast milk in small quantities. So we don't expect it to be very, very, very large quantities. We do, but we do expect it to be present. What the ramifications again of small doses of opioids over a very long period of time is, I don't know, and I don't think anyone does.
All righty, move on to the next question. And this is from Elizabeth. Elizabeth, you might need to clarify this. I'm not sure I fully understand with it, but we'll see. Excuse me, I'm not sure if I fully understand what you're asking, but we'll see if our panelists do. I understand about environmental exposure of children, such as formula being prepared on a surface where residue is. How does it build up besides ingesting a tablet?
I think, Elizabeth, it would be helpful to clarify what you mean build up in the system. I'm not sure what you're asking there.
All right, let's come back to that then. We'll move on to a question from Alyssa. Is there anything proven more effective than naloxone?
For the short-term treatment of acute toxicity, no, it's the best we have. There is another available reversal agent called nalmefene, but it's not being used in our area at all. I don't know if, Scott, if it's being used in Washington in the EMS in the pre-hospital environment, but I know that I don't know of any EMS agency or harm reduction agency that's giving out nalmefene, and it's just, the difference is it's much longer acting, and naloxone is probably a better choice in the long run.
Yeah, that's my understanding too.
And we did have 2 sessions that talked about nalmefene. The very, very first one, our buprenorphine panel, and then our session by the Washington Poison Center's managing director, Jimmy Leonard. He discusses nalmefene then as well. And Dr. Temple, I think I cut you off. Go ahead.
Oh, no, I was just going to echo what they said. I haven't heard of anyone. I've heard of the data coming out about the longer acting components of that, but I haven't heard about it being used in actual cases. So right now, naloxone, Narcan is our top choice.
You? All right. Do you have to be trained to administer naloxone?
Well, I would say you have to have a little bit of instruction, but it's incredibly limited, and you can be taught how to give it effectively and to the right people within a few minutes. So it's a very easy learning curve, and the drug is extremely safe. So teenagers, middle school kids, all ages can administer this safely, effectively, without any significant learning curve at all.
And I'd like to remind people of the Good Samaritan law in Washington and in Oregon, where you can administer naloxone and you are not going to get in trouble for excuse me, I cannot speak today, administering it. And I do want to put in a plug too for the poison centers for providing trainings on naloxone if you are interested. So please reach out to us. You can reach out to my email, which is plastered all over all of the materials, and I can get you connected to the right people. Okay. Have you had any infants that were given fentanyl by the parents?
So as far as I know, in the data that I have looked at, I have no reason to suspect that any of this was malicious intent. They all seem to be accidental. That being said, I guess I suppose I can't say for 100% sure that that didn't happen, but we don't really have a lot of suspicion, at least from the cases that I have, that anything has been purposely given to the infants.
I do also want to point out in chat here, I saw that Abby Jernberg, who's from Snohomish County Health Department, she put in a resource from the Washington State Department of Health. It's a lactation guide for substance use that might answer some of the questions that came up earlier. So that's in chat, so feel free to check that out. Our next question is, you may have already answered this. Is it possible that there isn't enough information about long-term effects from fentanyl smoke, similar to nicotine and secondhand dangers?
Yeah, I think that that's a correct statement. I don't think we know. Obviously, anytime you're heating something or you're burning it, you're going to create particulate matter and all sorts of chemicals that, the truth is we don't actually know what's in the smoke, and we don't know what the long-term effects are. I think that's fair.
A question from Michelle. I was recently around an individual walking near a group of individuals smoking fentanyl, and it put them in overdose within 10 minutes and caused a neurological shutdown. I've been told that smoke cannot cause this, but urine tests showed traces of fentanyl and Narcan was needed to bring them back. Could it have been an allergic response?
That's going to be a tough one to answer for us, I think, without knowing the details of exactly what happened. I would say that, as far as whether it could be allergic, yes, of course, we don't know because we don't know the specifics, but a transient exposure to secondhand smoke is not going to expose someone to enough fentanyl to cause significant opioid toxicity. So I think that's where I would kind of, there are extraordinary circumstances that I'm certain occur. And kind of getting back to what Scott was saying before, if there's scenarios where something gets on someone's hand and they put it in their mouth, et cetera, et cetera. So yeah, I can't comment on that specific case, but I would say for the typical case where you smell fentanyl and then you think it's disgusting, so you walk away, that's not enough of an exposure to be concerned about.
Thank you. So I'm going to skip down a couple questions just to get us onto a slightly different subject here. this is from King County Overdose Prevention. Can you tell us what you've experienced with families after an infant has overdosed? There is stigma and shame for parents in recovery and lots of concern about CPS.
Well, I would say,
Oh, go ahead, Scott.
I would just say from my experience, we have pretty limited contact after children are stabilized and treated. We don't do follow-up. We don't see patients at our poison center. So I don't really have any answer for what's going on with the parents. I imagine the parents can be quite traumatized by this, but we just don't follow them up. So I don't know that.
And so that's what I was also going to sort of comment on is we will see patients at the bedside, infants and young children who have been exposed. But often that's the very acute setting where things are still very tense and, the children are sick. There's a lot of guilt, a lot of shame. But at that point, when we are involved, it's really a focus on the clinical care and the safety teams and the CPS teams are the ones that will continue to follow as the patient is improving and then medically cleared. That is sort of when that assessment happens. So that's not something that we're always familiar with, but in the acute setting, it's something that is clearly very emotional and disturbing for the parents, and there seems to be a lot of remorse and guilt in that setting. But again, we don't tend to follow these from that perspective.
Seems like something that would be largely dependent on each individual healthcare facility and their policies. Okay, I'm going to ask this question, and I know Dr. Phillips, I emailed it to you earlier. So this is from David. He says, in my EMS agency, our protocols state that for medical fentanyl, not street fentanyl, we should use a neuromuscular blockade like, I'm not even going to try to pronounce that. I emailed it to you earlier. In fact, the protocol says do not use Narcan in bold and italicized letters. Do you have any input as to why the protocol might be this way?
Well, I think, David, thank you for your question. I think what you're actually referring to is chest wall rigidity, which is a phenomenon that's been reported with fentanyl. The idea is that you want to relax the muscles, and succinylcholine is a muscle relaxant, and it would do that. Although I don't have your protocols, I'm trying to read between the lines, and I suspect that's what the question is about. But clearly, if you're having trouble ventilating any patient that has chest wall rigidity or muscle rigidity, then that's an option. Rob, do you or Court, do you have any other thoughts on that? That's how I interpret that question.
Yeah, same.
Yeah, I think so too.
And I will put the plug out there that for any EMS folks that are in this session, you can call the Poison Center and we are happy to help you through all of the steps to treating your patients in the field and en route to a hospital. And be assured you will reach someone who can actually pronounce the names of the medications that you put in there, not me, who's a public health person. So you'll talk to one of our very qualified certified specialists in poison information. Alrighty, I'm going to have a couple questions now just on prevention and harm reduction. So what are your thoughts on steps that we can all take to prevent pediatric fentanyl exposures?
Safe storage and home naloxone, I think, are perhaps two of the most important steps.
Yep, I would just add on a third, that is community awareness, right, which augments the safe storage and home naloxone use, and sort of reassuring everyone in the community that having Narcan on hand at home is shouldn't be seen as shameful or guilty or anything. It's just a medication like anything else to help alleviate a severe situation, and that again isn't going to be used on the user themselves that's experiencing the symptoms. It's for loved ones around you, family, friends, other people in the community. So anyone can have naloxone at home. It doesn't just have to be people who are users or have known or expected exposures. Anyone can carry this at any time.
Yeah, and I would say that, we're probably providing poison prevention or safe storage information to a large group of the community, but I don't think that we have done a great job in the past expanding that to people who use things like heroin or fentanyl or methamphetamine. And this is an opportunity to do that. Safe storage is something that we can talk about, at harm reduction or, needle exchange or, lots of different points where we wouldn't normally be talking about poison prevention. But, most of these happened in the home, and, no matter what the substance is, parents, when their child gets into something, that was not something, usually the response that we hear is, I never even thought that that would hurt my kid, right? Or else I wouldn't have left it on the table. And, again, I'm talking about lots of different medicines, but also, fentanyl and meth and things like that. So I think there's an opportunity here to outreach to a group of people that we haven't really concentrated on. But this is very important. So if we can get that messaging, if you can, one of the things that we've been talking about is there are these bags that you can, that are designed for cannabis. They're called exit bags. They're just they're tiny bags. They're, tamper resistant. They've got a zipper with a little lock on it. They're not very expensive. And we've been encouraging people who have cannabis products to have those and to store their cannabis in there so that children can't get into them. And, while I don't have any studies to say that that would be a great idea for fentanyl, it seems like it would be a pretty reasonable thing to do, is come up with a way that's somewhat child resistant, where you can store your both your medications, but also in this case, the drugs that you're using.
I think that's a really important part of this message, that safe storage and up and away is not just pharmaceuticals and over-the-counter medications anymore. We really should be expanding that message into the community substance available.
Dr. Hendrickson, can you repeat the name of the bag?
Sure. There's a lot of different manufacturers. If you Google cannabis exit bag, you will see many, many, many examples of them. They come from very inexpensive, just sort of a little 3-number combination lock, to key locks, to very, very fancy and very, very expensive. But we have found some of them are selling for maybe like $6 or $7. So some of our harm reduction agencies here in Portland are looking into purchasing them now, and potentially, get a grant to purchase a bunch and then to give them out as a sort of pilot project to see if this might be effective.
All right, we have just a couple minutes left here. Dr. Phillips, you looked like you were about to say something.
I was not. I was just thinking that's a great concept also, Rob, for children and family services. To leave behind item would be great.
Yeah, it's a great idea.
So we have another question from King County Overdose Prevention. We often hear from folks that a seizure occurs with opioid overdose. We suspect this may be from hypoxia. Do you have similar reports of seizures for infants suspected of an opioid overdose?
Well, we didn't see that in our group. So I don't know if you did, Courtney, or.
No, none of that was reported. So I suspect that this is some kind of, hypoxic or convulsive syncope type of appearing episode.
Okay, in our final minute, I'm just going to run through the three of you to ask, what is your main action step you want everyone to take after listening to this today? Dr. Temple, let's start with you.
after listening to this, I would like everyone to check their house to make sure that all of your over-the-counter medications, your acetaminophen, your ibuprofen, your diphenhydramine, your other antihistamines, anything is up out of reach of kids, and your pharmaceutical medications are put away, and anything else that is potentially hazardous to children is locked up, including your chemicals under the sink. So safe storage.
Thank you, Dr. Temple. Dr. Phillips?
Narcan, naloxone, 5. I think that's so crucial, along with safe storage, that everyone should be carrying a reversal agent in their vehicle, in their bag, wherever they are. If they're around other people, the risk is there, and we don't have time to wait for EMS to arrive. So it's really in the hands of us as individuals to try to reverse this.
All right, Dr. Hendrickson?
Yeah, and
Rob?
yeah, sure. I would just obviously underline those two comments, but also say, anyone who has opioids in their home, there should be naloxone in that home. Even if you're taking 5 milligram oxycodone 3 times a day, 30 of those tablets is dangerous for a toddler. So they should have naloxone in that home. It just makes sense. But I think the thing that I would, since Scott took naloxone, I would say just expanding poison prevention information, expanding safe storage information to the group of people who are using fentanyl is probably the biggest thing I'd like to underline today. Just we have to be better at this, and there's lots of different ways to go about it, but these kids were exposed in their homes, and if you would think that if we could store these better for transport and in the home, then that would decrease the opportunity for infants to get their hands on them.
Wonderful. Thank you all so much. This was a jam-packed session. Lots of great questions and lots of great answers. So thank you so much for lending us your time and expertise for the last hour. To all of you who are still with us, please join our next session at 2 p.m. We'll be hearing from DH, which is the firm that works with the Washington State Healthcare Authority on the Friends for Life campaign. So they'll be walking us through that campaign. And stay tuned for the slides and recording from this. And thank you all again so much for joining us. Bye, everyone.